On behalf of Varanasi Cardiology Conclave and Medanta Hospital, Gurugram, I would love to welcome all of you to this beautiful evening, SEME, which we used to have regularly, and we are probably meeting after a few years. In between we had COVID, so there was no altogether a huge Indian Medical Association evening. So it's after a long time that we are all here, and we have some very special speakers for all of you, and after that there will be felicitation of secretaries and presidents of various organizations which we have in Varanasi. And Dr. Trehan had a very hectic day all throughout, since early in the morning at Allahabad, and followed by that he was at 10 o'clock in Varanasi. We received him at the airport, then went to Rudraksh, then went to Ramada for press conference and meeting dignitaries from various organizations of Varanasi. In the evening he was at Banaras Club answering various questions and talking about myocardial infarction and how to prevent and early precautions. And now he is supposed to be here in some time. He is already staying in Hotel Ramada only, but remember, he is a senior cardiologist and has been working and was on his toes since morning. So not wasting much time, as we have almost 4 lectures back to back, so would love that it all starts in time, and then we can have a question answer session, felicitation, and then we can start with our dinner and drinks, etc. So to begin with, the first lecture of the evening is pan-drug resistant sepsis. Is it really the lost battle, by Dr. Dilip Dubey, the Director Critical Care, who is based at Medanta, Lucknow. Dr. Dilip Dubey has done DM in Critical Care from All India Institute of Medical Sciences, and before that he has done MD Medicine from Safdarjung Medical College. So Dr. Dilip Dubey is working very hard with 3-4 colleagues of his at Medanta, Lucknow, and I have just listened to him. I had a small interaction with him at Banaras Club. He seems to be a great guy, and I am sure you all will love interacting with him. Dr. Dilip Dubey is a critical care specialist at Medanta, Lucknow. His main expertise is in the management of XDR, PDR infections, multi-specialty critical care, infectious diseases, and novel therapies like ECMO, CRRT, MAS, and Prometheus. He is the author of Indian Bronchoscopy Guideline and is contributing author Indian Guidelines for Antibiotic Prescription in ICU Antibiotic Guidelines and National Bronchoscopy Guidelines. As I have already told, he has done DM in Pulmonology and Critical Care Medicine from All India Institute of Medical Sciences, New Delhi, 2015. MD Medicine from Safdarjung Hospital, New Delhi in 2010. And before that, he did his MBBS from Vardhman Mahavir Medical College, I think it is the same as Safdarjung, in New Delhi from 2003. What I have understood in small interaction with him, that he is one person who can tell us a lot about the most important issue, and that is the rising antibiotic resistance. This is an era where all those antibiotics which we have been using right and left, the imipenems, the cephalosporins, they all have stopped working now. We know this is an era of pan-drug resistance, PDR, XDR, MDR. So this is all what is happening in our ICUs, in our hospitals. So we must know what all antibiotics are knocking our doors. There are antibiotics which are working even with carbapenem-based producing organisms are around. So those antibiotics which we have been using in the last 5-10 years, they are no more in use, as you all know. Some 20, 30, 40 years back we used to use penicillins, but it's no more being used because of the resistance. Similarly, the antibiotics which we have all used in last 10, 20 years, are they still working or they are getting obsolete? What is the microbiological report? How exactly Dr. Dubey is managing in Medanta, Lucknow? This is what he'll be telling us in 15-20 minutes of his lecture right here. So not wasting much time, I am requesting Dr. Dubey to kindly come here. Dr. Dilip Dubey, please come here, and all of us are waiting to listen to you. Thank you so much.
आसपास तो बगल में रस्सी तो वो भी किया है, अब वो कहाँ देंगे, मांगने पे कोई देगा जल्दी। उनसे फोन लगाए मैंने तो नंबरवा को कर्जे से बुरा दिखा रहे थे, तो एक बार कन्फर्म बात हो जाएगा मतलब इतनी से एक बार दिखा दे, बात करा दे कॉन्फ्रेंस करके।
Not a disease of an individual patient. So if you see, this is a review published in 2014. This review was started by the British Prime Minister in 2012. He initiated a committee. He commissioned this thing under Jim O'Neill. And the heading of the topic is tackling a crisis for the health and wealth of the nation. So in this study, they found that the antimicrobial resistance is going to kill 10 million people by 2050. So this is the leading cause of mortality by 2050. More mortality by antimicrobial resistance, by STR-PDR infections as compared to the mortality by the road traffic accident, diabetes, cardiac diseases or other chronic disorders. So this showed how important is to identify and treat and prevent prevent the development of antimicrobial resistance. Because antimicrobial resistance is not just a drug phenomenon, it's a leading mortality causing disease entity. So CDC proposed three main causes of antimicrobial resistance and development of HDR-PDR infections. One is the overuse of the antimicrobials, other is the inappropriate use of the antimicrobials, and third one is the environmental antibiotic pollution. So overuse can be rectified by the production of more and more medical graduates, postgraduates, while the environmental antibiotic pollutions can be controlled by regulations on the veterinary physicians. The most important part that is up to all of us is to control the inappropriate use. Or in the study, the data showed up to 30 to 50% of time, the empirical prescriptions are incorrect or suboptimal. So this is the area where practicing doctor, practicing physician, intensivist, other specialties have to do a proper prescription to avoid the inappropriate use of antimicrobials. So in 2016, WHO proposed a priority list for the bugs in the need of new antibiotic agents. This is a list that can be categorized as critical, high and medium. In the critical, there are three main MDR, gram-negative bacilli, who are most dangerous for the hospitals, ICU and the patients. So because of time limitation, today I will discuss only Pseudomonas aeruginosa. So for the management of HDR-PDR infections, we have two options. One is the new antibiotic discovery by the innovators, or second and most important is the smart use of existing antibiotic in our existing armamentarium. So regarding the new antibiotic discovery, how difficult it is. It took 5 billion to discover a drug at pharmacochemistry level, and ultimately 80% of the research got failed. So that's why the big pharma innovators closed their antibiotic research facility. If we see our data from Wall Street Journal, they showed in 1980 to 1984, almost 20 antibiotics discovered, but as the time moved on, at every 5 years, the figure dropped from 20 up to 10 and subsequently up to 5. Then in 2010 and 2020, there are few again antibiotic discoveries based on the beta-lactamase inhibitors. This is after the initiative of IDSA with the name of bad bugs and we need new drugs. But again, these new drugs have to use very judiciously because the smart use is always required. That is called as antibiotic stewardship. To use in right dose, right duration, right combinations, the prescriptions must be based on that fundamentals. So we will discuss about a case of pan-drug resistant Pseudomonas aeruginosa, which is one of the bugs from the WHO critical list. So the management is again going to be based on the principle of beta-lactamase inhibitors for the MDR GNBs. So if I talk about in few minutes regarding the beta-lactamase inhibitors pharmacology. So beta-lactams are the antibiotics which have a bactericidal effect on the bacteria. It includes the class penicillin, cephalosporin, monobactams and the carbapenems. And beta-lactamases are the enzymes which act on these beta-lactam drug and they destroy the beta-lactam molecules. The enzymes, as you all know, is classified as amylar class A, B, C and D. So we need some beta-lactamase inhibitors. These beta-lactamase inhibitors inhibit the beta-lactamases to save the beta-lactams. So beta-lactamase inhibitors belong to three generations. First generation already in use and there is resistant enough for the first generation. For the second generation, there are few innovations. The one drug, ceftazidime-avibactam, you all are almost using in your ICU practices. So these beta-lactamase inhibitors, they prevent the activity of beta-lactamases on the beta-lactam drugs. So this is how the principle of BL-BLI exists. When we combine the beta-lactam agents with the beta-lactamase inhibitor, the combination is BL-BLI. So if we see the classification of BL-BLI, So only 5 older BLBLIs were based on proper PKPD, pharmacokinetic, pharmacodynamic principles, and they are the rest-like combinations. In the novel BLBLIs, the ceftriaxone avibactam which we all are using is a rest-like combination again. There is a different class, a novel class of beta-lactam inhibitors is a BLBLI with BLE. That molecule is cefepime jidabactam. There are few other BLBLIs in the market which are wrong combinations. They are not authorized, these are more or less we can call irrational combinations. So avoid these beta-lactams. They are only the creation of pharma companies. So these are not authorized neither by the US FDA nor by the DCGI. So we move ahead to the management of parental resistant Pseudomonas aeruginosa. So I will discuss with a case scenario. So this is a culture which is a parental resistant. So these 8 classes, aminoglycoside, anti-pseudomonal carbaphenins, anti-pseudomonal cephalosporins, fluoroquinolones, BLBLIs, monobactams, phosphonic and polymyxins. These 8 class which include 17 antibiotics. Only these are supposed to act on pseudomonas. If there is a resistance to all these antibiotics, like in this culture sensitivity report, that is labeled as a PDR Pseudomonas aeruginosa. So this culture is showing even resistant to polymyxin B and cholesterol. So this is a case scenario. A patient admitted to us, a 50-year-old female resident of Nepal. She was admitted at some outside hospital in Lucknow for elective surgery. On post-operative day 3, patient went into sepsis with progressive septic shock, aspiration pneumonia, respiratory failure. She got intubated there and then shifted to Institute of CCM at Medanta, Lucknow. Patient was on at that time high ventilator support of 80% of IO2, high dual vasopressors and abdominal drain in situ. On workup, we find that there is severe anemia with severe thrombocytopenia, bilirubin level more than 6, severe transaminitis, AKI, and procal more than 180. So we label the patient as a case of post-op complicated intra-abdominal sepsis with aspiration pneumonitis, sepsis with MORS. MORS in form of refractory septic shock, AKI, acidosis, acute hepatitis, and thrombocytopenia. So this is the culture we got in this patient from the ETS spread. It was positive for Pseudomonas aeruginosa. In the sensitivity, we found that it was sensitive to phosphomycin and to the polymyxins. So this is labeled as MDR Pseudomonas aeruginosa. So there are 2 situations. Many times the Pseudomonas become so notorious that it becomes keep on developing resistance even on the right therapy. So after 4 to 5 days of phosphomycin with polymyxin B, the culture sensitivity report again came positive for Pseudomonas aeruginosa because of biofilm effect and all these things. And this time it developed resistance to phosphomycin. Now sensitivity only left for polymyxins. So this is labeled as the XDR Pseudomonas aeruginosa. We continued the treatment with the high dose of polymyxins and with the EDTA. As we all know in the research, the EDTA breaks the biofilm of Pseudomonas. So we keep on giving 75 mg twice a day EDTA along with the polymyxins. But in the next report, we found that again it persists in the abdominal tissue and it is resistant to phosphomycin and it developed intermediate sensitivity to polymyxins again. So patient was in ICU at day 28. We stuck with this situation and we are facing a parental resistant Pseudomonas aeruginosa. So then we thought of a new molecule under research. This drug completed only phase 1 and phase 2 of trial. That is a drug based on jidabactam. So this is a novel drug which is a triple action beta-lactamase inhibitors. Previously we have single action, double action BLIs. It's a triple action BLI. So it acts on beta-lactamase enzyme. Jidabactam have own antibacterial property and it also causes enhancement of PB3 targeted beta-lactam. So it acts as a beta-lactam inhibitor as well as a beta-lactam enhancer. But as I mentioned, when we thought about this drug, the drug just completed phase 1 and phase 2 trial. Phase 3 trial was about to start in US and Europe. Still, no patient was enrolled in the phase 3 trial. So we plan to use this therapy in this patient. So this was an incidence when we are planning to use a drug before the phase 3 trial. So we write a letter to US FDA that we want to use this drug in our patient for this kind of Pseudomonas aeruginosa. So they asked us to submit a 28-day treatment record of the patient, and after that they approved us that we can use this therapy if we got this drug. But again, we had a limitation. We also took permission from European Medicine Agency, but for compassionate use in our country there is no organized program. Then we again started working on BCGI level, and we got approval after 48 hours. We sent the isolate to the drug discovery lab, and we found that the drug is showing sensitivity on this bacteria with a zone of inhibition of 21 mm. So subsequently, we got a drug, we treated the patient on a 10 days therapy, and she was discharged after day 14 from the initiation of this drug. So what we see here, the beta-lactamase, they act on beta-lactams. The beta-lactamase inhibitors, they act on the enzyme to save the beta-lactam. This zidavectam-based antibiotic, sulfamidavectam, it also acts on beta-lactam to enhance the property of the drug. So that's the fundamental of beta-lactam enhancer. So this case was covered by Times of India at a pan-India level, and after that BCGI and Ministry of Health decided to start a organized compassionate drug use program in our country. So after our use, the drug was again used in 2 cases in India, one at Apollo Chennai and Global Hyderabad. So till now, there are 3 patients treated in our country on the compassionate ground, and after that 130 patients now enrolled in the phase 3 trials in the US and Europe. So this case I discussed is a case of true PDR infection. There is another scenario where sometimes because of error in the report, the culture sensitivity is labeled as PDR infections. So I will discuss a scenario. So a very VVIP patient, he consulted to us for symptoms likely associated with the UTI. So we advised him to go for a urine culture sensitivity. That sample was tested at one of the best lab in our country, and what we found that the culture was positive for Pseudomonas aeruginosa with the significant colonies, and it shows only intermediate sensitivity to cefepime. So this culture report is quite strange. When there is sensitivity for all beta-lactams, when there is resistance for all beta-lactams, there is resistance for colistin also. So how it can be intermediate to cefepime? So these things create a doubt in our mind. There may be some problem with the culture. So the patient and the administration they pressured us for the admission and further decision making in the treatment. So we asked them to submit the culture plate to our laboratory. And when we tested this isolate at Medanta microbiology laboratory, it shows a pan-drug sensitive bug. So how this is possible that one standard laboratory is showing pan-drug resistant while the Medanta microbiology is showing pan-drug sensitivity? So this is because few laboratories are trying to grow the bacteria multiple samples on single culture plate. So this is a wrong practice in infectious disease, and this is how the ideally culture to be grown. This is a culture plate from Medanta infectious disease and microbiology laboratory. So I will finish the presentation by the quote of great Louis Pasteur again. It is a terrifying thought that life is at the mercy of multiplication of these minute bodies. It is a consoling hope that science will not always remain powerless before such enemies. So we have to tackle such situations, one by the upgradation of the knowledge, and second by the upgradation of the resources. Especially if I talk about critical care infectious disease, the strong and ethical backup from microbiology laboratory is very, very important. And knowledge enhancement is always there to face this dynamic resistant profile of the bacteria. So it was greatly said by Dr. Trehan, if you are not better today than yesterday, when you tested last 24 hours. Thank you.
Thank you. you so much, Dr. Dilip Dubey. You are absolutely correct that we are entering into an era of MDR, HDR, and PDR, multi-drug resistance, extensive drug resistance, and pan-drug resistance, and we have to go on learning about the newer antibiotics, how to use, when to use, and antibiotic stewardship. That is the most important thing, and probably that is being done by the Indian government, and certain rules and regulations will be followed soon. Whatever questions and answers you have in your mind will be answered in the last, when we have all the 4 speakers here on the dais. So let us listen to the next speaker of the evening, and that is Dr. Sanjay Mittal. He is Senior Director Clinical and Preventive Cardiology, Medanta. He is a senior person who has worked a lot and has got a number of his papers in Indian and international journals, and he is an interesting person because he has an association with Varanasi also. His background is in Varanasi, he is in Delhi, so he has a soft corner for all the people from Varanasi. So I am sure the deliberation which he is going to give will be really interesting, and you will all love listening to him, and especially about the newer things in cardiology. And his topic for the evening is New Frontiers in Heart Failure. So this is something which will be of interest to most of you. Dr. Mittal, please. Most welcome from the heart of Varanasi on behalf of all the doctors here. Thank you, sir.
Thank you. Good evening to you all. After hearing about the multi-drug resistance from Dr. Dilip, it is exciting topic which I am going to talk about, equally dangerous and equally disastrous. We know heart disease, and in next few minutes I would like to cover this important topic of new frontiers in heart failure. Heart failure today is the final frontier of all heart diseases. Whichever heart disease we talk about, coronary artery disease, cardiomyopathies, hypertension, they may culminate into heart failure, unfortunately. And heart failure today is a syndrome which comprises of breathlessness, congestion, weakening of the heart function, and high filling pressures. It's a syndrome, not a single entity. Lot of new things have developed in the field of heart failure, and I'll just hurriedly go through because of the fact that I'll come to the cases which are going to be more interesting for you guys. So just to begin this solid thing is that this is a big problem and growing in all the practicing physicians and cardiologists. We know almost 16.4 million people worldwide have heart failure. Unfortunately, it is associated with a huge amount of hospitalization, repeated hospitalization, and the hospitalization rates are also going to increase over a period of time. And unfortunately, the mortality also is much worse. Almost 50% of people would not survive 5 years, much worse than most of the malignancies, if I talk about. But the problem in India is much worse. If you look at the Indian population, almost gets heart failure almost 20 years earlier. If we talk about the ages 53 as compared to 73, the other thing is the higher hospital mortality in India is there, almost 10 times higher than what reported in the Western world. And 6 months post-discharge mortality, unfortunately, if the person is lucky to be discharged, then also the mortality is high in 6 months, almost 28%. There could be several reasons. We are different gene pool, but more importantly, we unfortunately do not detect the disease early. The patients delay the symptoms, and that is why they delay going to the doctors with their symptoms, and that is one of the reasons. Besides, we are the diabetic and cardiovascular capital of the world, having the maximum amount of cardiovascular diseases. Also, there is an inertia in the physicians to actually detect heart failure. specifically the preserved heart failure I talk about. And these are the reasons why the problem persists in a high. In Trivandrum heart failure registry, it was seen that almost only 25% of people, they were on guideline directed medical therapy, whereas the recommendation is almost 100% of them should be, only 25% of them were on guideline directed medical therapy, probably going to be the reason for worsening of heart failure. The second important thing is there is no longer heart failure as an entity when the person is coming panting to us. There is all the gamut of information here. Stage A, which is the commonest reason for heart failure, almost 22% of the population there would be in stage 8 heart failure, where the person does not have any symptoms or any cardiovascular defect, but has a high risk of developing one in the future in the form of existing coronary artery disease, hypertension, diabetes, or a family history of heart disease. Stage B is when the person has heart defects, weak heart, ejection fraction is down, but no symptoms. Stage C heart failure is when the person first time presents with breathlessness or effort intolerance to the patient, to the doctor. And D is when, despite medication, the person cannot be improved. Also today, this is something which has been ranked. Heart failure has to be classified into one with ejection fraction, left ventricular ejection fraction less than 40 or above 50. Reduced ejection fraction or above 50, which is preserved ejection fraction, because the management strategy changes. Let me go to the cases. This case was a young gentleman. He was a medical intern who presented to us with a short history of breathlessness of exertion, just 2 months, with a blood pressure which was allowing some medications, but he was grossly congested, tachycardic, pulse rate was 122, and the respiratory rate was 22 beats per minute. And JVP was elevated, and the person has pedal edema. Fortunately, the creatinine was okay, but the markers of heart failure in the form of NT-proBNP was quite high. The echo was done as the first point in time, and those who look at the echocardiograms today would imagine this ejection fraction is very poor, only 15%, when the normal range is 55 plus. All these things, along with high filling pressures, was observed. We did a CT coronary angiogram, which was normal, excluding coronary artery disease, young chap. We did not want to do the regular angiogram. We also, during the stability period, did an MRI to look at what was the amount of myocardial scarring, which is a routine which we should do in people who have no non-coronary ischemic cardiovascular disease. We did put the person on nitroglycerin drip to reduce the blood pressure, congestion, venous pressures would be reduced. IV furosemide drip was started, and supportive care was started. Within 2 days, the person stabilized. He would put off the drip of furosemide, and injectable furosemide was started. We could start a small dose of beta blockers and avoibridine. Nitroglycerin also could be stopped. At discharge, after about a week of the admission, the person could be discharged on ramipril, the ACE inhibitors, spironolactone, bisoprolol, and furosemide. We had a regular follow-up in our heart failure clinic, and we found that slowly and slowly we could lift up the ARNIs, the standard 4 pillars of cardiovascular heart failure management. And at 2 months, the full dose of heart failure management the person could tolerate, young chap. And look at what happened in about 6 months, 1 year of the completion of his full drone medical therapy. His ejection fraction completely normalized, and a person who was listed for heart transplant, we had come off the heart transplant list for good. So for that matter, all the 4 pillars of heart failure medications today in reduced ejection fraction, this has been a huge bit of 5 years development in the research over the 5 years, over development of new molecules, and this has resulted in these 4 pillars. ARNIs were the first one in 2016 to come as a big pillar. Beta blockers, once contraindicated, are the star indication for all heart failure with reduced ejection fraction. Mineralocorticoid receptor antagonists are a third pillar, and the 4th pillar is the repurposed diabetic drug. In today's world, we are not using this drug as much for diabetes as much for heart failure, because in DEPA-HF trial as well as Emperor reduced trial, it was as effective as any other molecule in reducing mortality as well as morbidity for recurrence hospitalization in reduced ejection fraction patients. Besides this, there are certain other things which are coming up. Vericiguat, another molecule in people who have repeated hospitalizations. We should always test these people for iron deficiency, because this is an important contributor not only for development of anemia, but also for the fact that the iron is a component of many of the mitochondrial enzymes responsible for muscles, energies, and this is important manufacture for good physical being of a person, reducing hospitalization for heart failure. So ferric carboxymaltose should be given if the person is detected to be iron deficient. We should not forget about good lifestyle changes and the vaccination for influenza virus. And this is something in the heart failure clinic we look at all these patients presenting with heart failure to be in the heart team approach, where a cardiac surgeon, interventional cardiologist like Dr Rajneesh Kapoor, and myself as a clinical cardiologist, Manish, we actually sit down with the patients and see what is the best possible management for that. We have been able to reduce the rehospitalization rate in our heart failure clinic to less than 11% in our clinic in 1 year's time, which is as much as the best of the trials situations there. A word about heart failure with preserved ejection fraction. Unfortunately, as the age of the patients are increasing, we are surviving the acute brunt of events, more coronary artery disease, diabetes, and hypertension. The heart failure with preserved ejection fraction population is increasing. And this is a big lacuna. Whenever a person comes with breathlessness, we do an echocardiogram. And when the echocardiogram is done, the ejection fraction is normal. So this person, unfortunately, we say, is not cardiac. So that is a wrong concept. Unfortunately, this is a very big misnomer. Very commonly, we are missing heart failure with preserved ejection fraction. And mind it, if a person is old, more than 60 years of age, hypertension, atrial fibrillation, or lady for that matter, we should definitely suspect this person could be heart failure with preserved ejection fraction. And unless we suspect them, there have been certain guidelines, the H2PEF score, and also the HFA-PEF algorithm, which has been given with various organizations to felicitate where to suspect and diagnose heart failure with preserved ejection fraction, because it also ultimately has a similar kind of worse outcome as the heart failure with reduced ejection fraction. Word about one of the cases, this 84 years old gentleman, I took the slides from Dr. Manish Bansal, who's my colleague here. He had hypertension and not on any antihypertensive medicine for last more than 5 years. Borderline diabetes, if you can look at the ventricle here, there is hypertrophy, and the short axis also shows very good ejection fraction. The ejection fraction was 65%. But when we did a polar map on the strain rate imaging, it was a bullseye plot which very clearly showed a situation of cherry on top of the cake, which means this is a suspect of amyloid, a thing which we commonly miss, especially in the elderly population. The restrictive film pattern, again going the same way, that it possibly was a restrictive cardiomyopathy. We did further evaluation, and what was found was that although free light chain assays were normal, immunofixation was normal for monoclonal pattern, but the MRI scan for the technetium pyrophosphate scan, which was done to rule out ATTR amyloidosis, was positive. And this is why we could detect this is ATTR type of amyloidosis. Nowadays, we have a disease treatment for this, tafamidis, although it's very costly, but there are people who can afford that. Almost 1 lakh a month cost of the treatment is there. I'll go quickly to the third case, the revascularization in people with heart failure who have come to us with ischemic cardiomyopathy. We have to look at the viability, we have to look at the completeness of revascularization and risk of comorbidity. Let me give you an exact case here. This is an interesting case because from Allahabad and Lucknow, this patient came to us, and this person was actually denied any kind of angiography or intervention because he was too sick. The BP was too low. He was on triple inotropes when he came to us. Acute kidney injury was there, the creatinine was high, very poor urine output was there, liver dysfunction was there, and there was urosepsis as well. So this is how he came here. He was in shock with triple inotropes. He had left ventricular failure with the SpO2 dropping down despite 4 liters of oxygen. Acute kidney injury, the creatinine was 2.2. Ischemic liver injury was there, and sepsis was there. Ejection fraction was bad, and there was severe mitral regurgitation. So what to do? Let him go? The person had come to us with some hope. What we did was we started antibiotics, we put intra-aortic balloon pump for support, and we let the person stabilize. And you can look at how the things happened over the period of days. Within 2 days, the creatinine and the urine output started to improve. Within 4 days, the liver function improved. And over a period of time, we had time that 4 days later, the inotropes were completely off. We could do an angiogram subsequently, which showed that the person has a triple vessel disease. The right coronary was totally occluded. The left main was tight, and the left anterior descending was tight as well. And what we did then, we wanted to see whether it is too far gone, all the muscle is dead, or something can be done. We did a PET scan here, and we found that there was definitely a lightening up. If you see the apex, the top of the picture, there was some metabolism which was there. There was about 15% of area which was dead, but about 25% area which was hibernating. This means if we give this muscle some blood, this muscle would improve. So after 14 days, after the cultures, infections, and everything was settled down, we could operate on this person. We did a bypass surgery and mitral valve repair, and this person could be discharged after about a week of this particular surgery, and we could complete 1 year's follow-up this patient. So no person, in our opinion, is inoperable unless we give our full throttle. This is how 1 year later we could find a person. So the question was on STITCH trial. Let's not go into the details, but this STITCH trial was not designed to answer the question whether viability testing is going to lead us to benefit or not. Last case I am going to show you is another approach which with the vision of Dr. Trehan we have in our hospital. This is a multidisciplinary approach. As I said, this is a heart team approach where any person who comes to us with heart failure is to be looked at from the surgeon, the interventional cardiologist, and a clinical cardiologist to look at the proper treatment modality for him. This patient was a 67 years diabetic, hypertensive, triple vessel disease which was diffused, presented with heart failure, severe left ventricular dysfunction, ejection fraction 25% with moderate mitral regurgitation, also had COPD, and creatinine was 2.7 milligram per deciliter. A calculated Euro score was 30, that means 30% chance that the person would not come off the surgical table. You can look at the angiogram. It was showing diffuse disease, hardly any target vessels were seen in the right, but the left vascular system was giving us a little bit of hope. Ejection fraction was poor, 25% ejection fraction, almost seemingly akinetic apex and complete loss of the muscle contractility there. However, if you look at the hibernation, the lower part shows everything filling up. So this was a hugely viable myocardium. So we, in this particular scenario, have been using counterpulsation, enhanced external counterpulsation, to stabilize the person with left ventricular dysfunction and give some breathing space for the kidneys to recover and give a chance for this person to get a final treatment of bypass surgery. So we did 20 sessions of ECP on this patient. The ECP brought down the creatinine from 2.7 to 1.5, ejection fraction improved from 25 to 38%, and MR almost vanished out. And this person could then be operated with a Euro score of just 4.8. He received 3 grafts and was able to discharge in 8 days of the bypass surgery, and he's doing, after 2 years of follow-up, he's doing pretty good. We have about 74% people, we have done ECP with the deteriorating renal function, and almost 60% of people actually improve or normalize their kidney function. And this thing, under the aegis of Dr. Trehan, we have been using frequently. There are about 27 patients who have undergone ECP to stabilize before a bypass surgery. And I looked at the data, there was no in-hospital mortality in these 27 of the worst kind of patients, and the 1 year survival of all these patients were 100%. And if I look at the 5-year survival, on an average, it was 92%. So this is something which is definitely a hope for a person with heart failure. So I will stop my talk here. The message I want to give is heart failure is a deadly disease, much worse than most of the malignancies in combined totality. We have many options available besides the transplants and assist devices, which Dr. Trehan is going to talk about briefly. But even if the existing heart can be handled carefully by proper time and proper medication, proper lifestyle changes, proper interventions, and proper surgical maneuvers, if they are available to us, we can save many of them and give them a good life. Dr. Rajneesh Kapoor is going to discuss about the interventions in valvular diseases, and nobody better than Dr. Trehan is going to discuss about the surgical counterparts. Thank you. Thank you for your attention.
Thank you so much, Dr. Manish. I must say that your lecture was really mesmerizing, and the way you have worked and the way you have elaborated, especially in the post-COVID era, it was really something to learn, because left ventricular ejection fraction being only 15% and the patient is seen walking is something really amazing. That is all I can say. It's amazing for us. We have seen a lot of patients in our pediatric ICU having ejection fraction of 30%, 35%, even then it's very difficult. But then most of them, they come out to be patients of MISI. So there the treatment becomes a shade different, but the flow of chart of the drugs which you have used, the newer and heart failure medicines which you have mentioned, and the way you have been dealing, it is just superb. It's a eye-opener for most of us, and I must say your presentation and your everything was just superb. Thank you so much, sir, for the beautiful presentation, and I'm sure the next 2 lectures are going to be further energizing, because the next guy which we have is Dr. Rajneesh Kapoor. Dr. Rajneesh Kapoor, I'm associated with him for more than 10 years, and he's one guy who started coming to Varanasi long back. When he was a young person, I still find him to be pretty young, but he purposely keeps his hairs white so that the patient, they feel that he is getting very mature, but he's a young guy, let me tell you. Amazing cardiologist, and he is one person who has been really, who has taken up the cardiology department of Medanta really to the next level. And so let me call Dr. Rajneesh Kapoor, excelling structural heart interventions at Medanta, and a good news that Dr. Naresh Trehan has just entered the hall. And on behalf of all the doctors of Varanasi, I would like to welcome you, sir. Sir is already sitting here, and very soon, after Dr. Rajneesh Kapoor's lecture, we'll be listening to him. So keep your patience. The main person, the magician of our country as a cardiologist, is going to be with us very soon. So in the meantime, let's listen to Dr. Rajneesh Kapoor. Please, Rajneesh boss.
Thank you, Dr. Alok, for very exciting introduction. Whatever age I have, I still consider myself very young. Okay, so it's really very delightful to be here amongst this elite gathering, and always a privilege to be in Varanasi. I feel I have a very strong connect with Varanasi because, you know, yes, the history started about 10 years back once, you know, I started coming to Varanasi almost every month. And that time, besides doing some cases and doing outdoors and meeting many people in Varanasi, I have fond memories of having a very good lunch with Alok ji and at Popular Hospital many times. So that time Varanasi didn't have all these beautiful roads and all that. It used to take me 1.5 hours from airport to reach city. So good to see all facelift of Varanasi, and really a privilege to be here. So I'll just take up my topic, which is structural heart interventions, which is a newer paradigm in field of cardiology, and how we are excelling with these interventions at Medanta. So I think the main perception with all doctor community about cardiac interventions is coronary interventions. So that perception is changing, and there is a lot more we are doing in the field of cardiac interventions. So coronary interventions, which is coronary angioplasty and stenting, we know that is available every nook and corner now and done almost in every cities extensively. But that is not the whole flavor of cardiac interventions now, although that's a major domain. But the newer recipe for cardiology is structural heart interventions, whereby there actually so many innovations have happened that we are now replacing valves. Aortic valve replacement is percutaneously, which is being done, is getting more and more popular with advancing age aortic stenosis patients. We are also almost replacing the mitral valves, but that is still only indicated with patients who have degenerated mitral surgical valve at the mitral position, which is done in the past. There is lot more to that, and that's my job to take you through the journey of a structural heart interventions. And I can tell you, once we talk of these complex, complicated interventions, we at Medanta are fully geared up with all the infrastructure and a heart team, very robust heart team, whereby we take all these complex decisions with a cardiac surgeon, interventional cardiologist, a clinical cardiologist and a non-invasive cardiologist and a cardiac anesthetist sitting together. And that's where I think our practice over the years have also changed. Previously, we used to have a patient in the OPD, decide, do the coronary intervention ourselves, no team approach, but now clearly we are sitting as a team and taking a call together, and that also leads to the best possible decision for a patient and best outcome for our patients. So that is one part. And as far as volumes are concerned or expertise is concerned, I think very clearly the data suggests, the volume suggests that we are leading from the front, and we are #1 institution in India who has done the maximum work in this field of structural heart interventions. So I'll show you straight away some cases. I think that would be more exciting and more, it gives more clarity to the audience here. So this is a percutaneous aortic valve replacement, which is called TAVR, transcatheter aortic valve replacement. So this is indicated mainly for patients of aortic stenosis. And we know aortic stenosis is a disease of elderly. As the age advances, the aortic valve tends to shrink in many patients. The incidence of aortic stenosis, it increases beyond 65 years, and further beyond 70 years it further increases. Also, we know once the patient has an advanced age and aortic stenosis, the morbidity of surgical AVR also increases. But still, there are many patients who are in robust health where surgical AVR is low risk and obviously should be offered to those patients. So I am not saying that transcatheter aortic valve replacement is the decision making in all aortic stenosis patients beyond 60. It all depends on the risk of the surgery in that patient. Less than 60 years of age, I think TAVR should not be considered at all for any patients, because it would be criminal to give a bioprosthetic valve in a young patient, because the durability of this valve is around maximum 10 to 12 years, not more than that. So it can degenerate. So for those younger aortic stenosis patients where bicuspid aortic valve is the main reason, mostly surgical AVR still is the mainstay therapy. But older patients with aortic stenosis, specifically once they are older than 65 years of age, that's where TAVR comes into picture. That's where we need to discuss transcatheter AVR with these patients, and if they can afford, I think yes, it is a very patient-friendly procedure with good outcomes. So I'm presenting this first case as a 69-year-old patient, critical aortic stenosis. Patient had bad pulmonary functions, and there are some CT parameters which we have to analyze extensively sitting in the CT room. Based on that analysis, actually we can execute the best possible TAVR. We should know each and every detail of aortic annulus, sinus of Valsalva, the coronary ostial heights, whether there are any red flags for that patient as regards the TAVR is concerned. So we have to be very, very clear, because once we deploy a valve, if there are some red flag signs, the case may go in a different direction and catastrophe can happen. So we have to be very clear about those parameters. So this patient, as a heart team discussion, was not a good candidate for surgery. So that's where the TAVR was planned. And this is how the procedure is actually planned. We keep a pigtail into the aortic sinus and one pigtail catheter into the LV. So, and then once we have done this, the next step is a balloon aortic valvotomy. We dilate a balloon at the aortic annulus. So now we are ready to deploy a valve, all percutaneously through the groin access, and then we start deploying the valve. This is a self-expanding valve. There are various valves available. This is one of those valves, and while deploying, once we have partially deployed, we keep checking everything with aortogram, with the contrast into the ascending aorta, and then once we are almost confirmed that we have taken care that valve is being deployed precisely wherever we want it, then we deploy this valve fully, where now it becomes non-retrievable valve, and this is how a TAVR is done. This rim contains a newer bioprosthetic valve, and this squeezes the previously diseased valve underneath it. So valve is replaced, patient is treated of aortic stenosis, the hemodynamics improve immediately. So it is a good patient-friendly procedure. This is the first case. Second case, 70-year-old male patient, hypertensive, coronary artery disease, previously had angioplasty. Again, a critical aortic stenosis with moderate AR with LV dysfunction. So age is 70 with LV dysfunction. Again, always as a rule, we sit as a heart team and take a call. Again, this was decided that this is surgically high risk case for surgical AVR. Planned TAVR steps, I think I have shown you in the first case. Now only difference in this case is that this case had a red flag sign of a low coronary ostial height. In those cases, we have to be a bit more particular in protecting the coronaries. So you can see, can I have a highlighter? Okay. So you can decipher that there is a wire going into the coronary arteries. So that is a coronary protection as a step we are using. So once we deploy a valve, it should not occlude the coronaries, and because if we are not doing that and there is a low coronary ostial height, if that gets occluded, patient cannot be salvaged. So we have to take care of this prior to this, and then once we deploy a valve, once we are taking the valve down, we place a stent into the coronaries. So if there is any clue of coronaries getting occluded, we can just take back that stent across the ostium of the coronaries, left main, and make a chimney. So that is a salvaging pathway, salvaging step. If there is a red flag sign only, it has to be used, and this is a valve deployed. But after that, we keep checking with the aortogram, with the contrast, whether coronaries are flowing briskly and there is no chance of occlusion. If there is nothing happening, we can just take out that stent and no need of deploying that stent. So in this case, we didn't require that, but valve was placed nicely and coronaries were flowing. So TAVR is accomplished successfully. There is another procedure which is also now required by many patients who are surgically high risk for a redo mitral valve surgery. So mind it, this is a procedure which is indicated for those patients who have already undergone a bioprosthetic valve at the mitral position in the past, and now that valve has degenerated. So that degenerated mitral valve is now producing havoc in the heart, giving rise to a lot of high PA pressures and pulmonary edemas. Patients, usually such like patients, are in bad state, and doing a redo mitral valve is obviously going to be a morbid procedure in many of these patients. So if patient is not again fit for surgery, redo surgery, then we go for a transcatheter mitral valve replacement. So this is one of those cases. I am just giving you a glimpse of a procedure. Now in this case, we go through the femoral venous access. So femoral vein, IVC, and into right atrium, and then we take a puncture into the interatrial septum. So this is all done by under the supervision of a transesophageal echo, being guided to us by our non-invasive cardiologist. Dr. Manish is sitting, he is mostly part of that. Dr. Mittal is also there. So we take the help of our experienced non-invasive cardiologists to guide us, because that puncture is very important. If we have to accomplish this procedure successfully with very good result, that puncture in the interatrial septum is very, very important, because we have to take that passage, that valve has to take that passage, and it should go smoothly into the mitral annulus. So this shows that how we go. Now femoral vein, IVC, RA, puncture into the interatrial septum, and then we enter the LA. From LA we cross to the LV through that mitral valve, which is degenerated. And once we have done that, we take the valve down. So this valve is being advanced through the same route over the wire. So this valve, once we place that, there is one clue, there is one rim which is visible here. If you see very carefully, you will see a circular rim. So that rim is of the previously deployed valve. So we have to inflate the valve, new valve at that position, and that takes care of the previously degenerated valve, and the new valve starts functioning immediately. So this also takes care. So we have replaced the mitral valve, so hemodynamics improve straight away. So this is the patient which had a mitral stenosis and a mitral regurgitation because of the previously degenerated valve, and once we have done that, patient was much better. Another flavor of structural heart, paravalvular leaks. So this is another case whereby at times, we encounter these patients where there is paravalvular leak just coming from the vicinity of the previously deployed valves. So we can also plug these holes percutaneously, almost the same route as I have shown. This is how it is done. Again, IVC, RA, LA, and then through that hole which is there, we advance a small catheter, and through those small catheters we advance a AVP, which is a vascular plug, and we can plug that hole with these devices to occlude that rent which is there, which is causing a paravalvular leak. All these things, all these procedures are quite complex, has to be done with proper planning, and in this case also the transesophageal echo is very handy. We can't do these procedures without that help. So that is where we keep requiring Dr. Manish or Dr. Sanjay Mittal's help always in the cath lab. So this is the plug occluded. Last case I am showing, this is another case which was very tricky. The mitral annular calcification can also lead to mitral stenosis in the old age. Extensive MAC. So this was a lady who had extensive mitral annular calcification causing mitral stenosis, almost 78-80-year-old lady. She hailed from Bikaner. She was not coming off BiPAP. She was constantly desaturating. She was constantly in pulmonary edema, not able to lie down, orthopnic. We tried for 10-15 days. We discussed the surgical intervention, but she was quite old, very obese lady, so not fit for surgical intervention. So I tried this innovative procedure. Now this is only done few times throughout the world. This is I think searching the literature, I could find I could actually find only 2-3 cases having done prior to this. So this is again the same route, RA, LA, and then through the mitral annulus with the wire there, but this time I used the 2 lithotripsy balloons. Now lithotripsy is one modality whereby we deliver shock waves to the calcium surface, and these lithotripsy balloons are giving shock waves to crack the calcium, and once the calcium gets cracked, the compliance changes. So that led to decrease in the gradients across the mitral valve, and lady literally improved. Now this is done almost a year back. She has done much better. She still connects me with the video consult from Bikaner, and she's doing much better. I'll just show you one very exciting one more case which came to us few months back. In fact, she was a patient of Dr. Trehan, and Dr. Trehan discussed with me that how can we salvage this patient. This was very, very interesting and very different kind of subset which we had. So this is a lady who's 38 weeks pregnant, previously had 2 spontaneous abortions, third gravida. So this is a very precious pregnancy and already 38 years. So now she landed to Medanta almost at 6 months of pregnancy. This time once she started having problems of breathlessness, she got investigated and it was diagnosed that she is having critical aortic stenosis and moderate aortic regurgitation. 38-year-old, gravida 3, previous 2 abortions. 21 weeks it was found, but they wasted further 5 weeks, and once they came to us it was more than 6 weeks already. So issues were risk of continuing pregnancy without treating a aortic valve disease. Surgical AVR considered, but obviously you can imagine doing a surgery in a 6 months pregnant lady for a valve, and then she continues with the pregnancy. I think there is a threat to fetus. TAVR we considered. So once we considered TAVR, the valve was not calcified. That was one issue. The radiation risk to the fetus was another issue. The rapid ventricular pacing, which we usually require doing a transcatheter aortic valve replacement. But having said that, we discussed with the family at a greater length. The fetus was really very precious to be salvaged. So having understood pros and cons, family decided to go with this. And then on the day of procedure, we took all precautions. This is an echocardiogram, and this was the dynamics. Mean gradient of 63 across aortic valve. Procedure planned under conscious sedation with constant fetal monitoring. This is how it was done. As I showed the steps, I am not going into that again. So there were some other complications happening in the case. I am not going into detail of that. But finally, a procedure was accomplished very successfully. Aortic stenosis was treated. And after the next day, we checked all ultrasound, seeing all the well-being of the fetus. It was all fine. This is the valve deployed, AS treated, and after 3rd or 4th day, patient was discharged. They were from this area only, Bihar side, and they were in touch with me. We were checking out with the fetal well-being constantly with the family, and then the good news came around 15th March when the family called me to announce that she has delivered a very healthy baby. So that was very gratifying, and I think this is where we keep working so hard to search for these gratifications. So I will end here, but I'll end with just 4 lines, which is really required, and one should really listen to this. मुश्किलों में भाग जाना आसान होता है, हर पहलू जिंदगी का इम्तिहान होता है, डरने वालों को मिलता नहीं कुछ जिंदगी से, लड़ने वालों के कदमों में जहान होता है.
Thank you so much, Dr. Rajneesh Kapoor. Special thanks for the beautiful interventions which you showed here, and I think you are one of those that's really a complete ones, and we are really proud that we are the whole of Varanasi and all the doctors. We are all associated with you for more than a decade now. So thank you so much, and hope to have more lectures and more learnings from you in days and years to come. And let me tell you, I have one more association with Dr. Rajneesh, that he happens to do his MBBS from Amritsar, and that happens to be my Nanihal. So one more connection I have developed after I was going through your details. So thank you so much. One more connection we have. Now coming to the most important part of the day, जिसका मुझे था इंतजार, वो घड़ी आ गई, आ गई, आ गई. Let me tell you, we are all fans of our Prime Minister Modi ji because he is our Prime Minister. And if you come to a person who is of equal level to the Prime Minister in medical field, who is he? One and only Dr. Naresh Trehan, the person who has changed the entire scenario of our country, and the way he is taking us ahead. I tell you, maybe thousands and lakhs of people, if they are alive today, it's all because of his blessings. The man who has done 48,000 open heart surgeries and is still working since early in the morning. I received him at the airport at 10 in the morning, and it is going to be 10 in the night. 12 hours continuously he is working, and even today he has done almost 5-6 meetings, and he is still active and right to be in front of you. So welcome, sir. The whole medical fraternity of Varanasi welcomes you. Please come here. We can't wait more. We want to listen to you. And after that, he'll be open for all the questions which you have in your heart. Dr. Naresh Trehan and you, thank you so much.
So by mentioning the names that you did before my name, ये मरवाने का program please बंद करो. हाँ, वो मैं तो कह रहा हूँ कि मुझे नहीं पता था कि दुश्मनी भी है आपसे. अच्छा, ये और देखा आपने, कपूर साहब ने तो बताया कि the ones who fight, वो जहान उनके पैर पे होता है, तो ये रोज लड़ाई इसीलिए करता है. अब मुझे समझ आ गई है. So, आप लोग तंग आ गए हो गए अभी तक, क्योंकि डिनर टाइम हो गया. मुझे तो भूख लगी, पता नहीं आपको लगी नहीं लगी. So we'll try to make it as short as possible. So basically we are talking about the concept of Medanta. Medanta क्यों बना? क्योंकि first time, and even till now, this is the largest private hospital ever built in this part of the world. The idea was learnings from Escorts Heart Institute, which I created and came back to run in 88, that the single specialty was at a much higher level because we created the full Heart Institute. But the other specialties, when we needed them, were not of the same level because that was not on the same platform. So when you look at it, institutions like Harvard, Mayo, Cleveland, these are the institutions which are large enough to accommodate all the best of all the specialties on the same platform, so that the best of kind of doctors, technicians, teams work together to give the patient the best possible outcome. So that's why Medanta, 1250 beds, now 1400 beds, was created. The second most, so the infrastructure was built to the level that the safety of the patients was the first concern. The ability of doctors, nurses and technicians to deliver the care was convenient with precision and swiftness was the second concern. And third was how to take care of the families who are worried sick about their patients being in the hospital or in the critical care. So all these things were taken care of, and if you have visited, you would have seen the size of the corridors is 10 feet. You know, so there is a lot of things that we put in. Every 18 beds has a separate air conditioning unit so that you don't mix air, infection doesn't happen. That's why when in COVID, we were able to repurpose the hospital very quickly. So all these safety features of international standards were already put in. Then the second thing was technology, which was easy to get. You just have to buy it. We went around the world and got the equivalent, and I'll show you what kind of technology we had put in. But the most important part was finding the human capital, that means headed by the chairman who would head the institution. I'll give you a little bit once we are going through, but I just want to give you a preamble that we were lucky to find the best of kind because they were benchmarked internationally, not nationally. They were at a stage of their life where they were ready to teach, give their skills to other juniors and teach them and bring them up. And third, most of all, that they would have impeccable integrity and compassion. So nobody touches money in Medanta. The fee is collected by the hospital, taxes deducted, and everybody's the salary goes into the bank account. So that there is no cash transaction, which is very important in my thinking, that that with dealing with cash is not a good omen for medicine, although I don't hold it against anybody, but that's how we've done it, not from now, from when I came back from America in 1988. It has worked well. The doctors have been quite happy with it. And the work has grown so much that we are still, in spite of paying all the taxes and everything, we are still making enough. We are quite satisfied with what we make. So it's worked very well because that's what the whole idea was behind building this. So now, so much so that over the years, for 4 years in a row, Medanta has been named as the best private hospital in India by Newsweek International, which studied 28 countries. And not only that, we have been named in the first 150 hospitals of the world. So that's a very good satisfaction we have that the system that we have followed has actually produced the right results. Since then, of course, we opened in end of 2009, actually in 2010 beginning. We have continuing the same mission and vision, and keeping the principles intact. We have now 5 hospitals which are already operational, and the 6th one, so we have Gurugram, Lucknow, Patna, 2 small ones, one in Indore and one in Ranchi, and the 6th one, Noida, is actually out of the ground, and we hope to actually commission is within the next 18 months. So this is all grown out of our own systems, protocols, and if you go across, you'll find the same standard in every institution of ours. In fact, if you were standing in the lobby, you closed your eyes, you would not know whether you are in Gurugram or in Lucknow or in Patna, because these are the new hospitals, and that's what the whole idea was. So that's the main concept that I wanted to share with you, because then I'll go through very fast, is the fact that we follow the institutional sort of system of creating vertical institutes. These are some of the examples that are here of the major institutes. And you'll see we have the Heart Institute, which will work together, as Dr. Kapoor and the previous speakers have said, that we all work together as one team. The cardiologists, the surgeons, we practice the heart team, patients get the benefit of all 4 doctors, whether they are clinical cardiologists, whether they are imaging cardiologists, whether they are interventionalists or surgeons. We all work together, and we actually, in complex cases, we sign a piece of paper. We give collective counseling to the family, and then we fill up a form and then sign it together that that's our collective opinion. So that way, the patient gets the best possible treatment. It does not, nobody is pulling that I'd like to do the surgery, or the cardiologist would like to do intervention. That stress doesn't exist. So we work together, which Dr. Kapoor, I think, forgot to answer. or mention that all this TAVI stuff he does and all our cardiologists, the surgeon is a very much part of it. So it's not that it's a single effort, but we are standing behind right now, and they become so good they don't need us most of the time. So that's a combined philosophy, like in Heart Institute, same in Cancer Institute. Like in cancer, we will have a subspecialist for every part of cancer, every part of the body. So we have a head and neck surgeon, neurosurgery, of course, onco-neuro, onco-head and neck. There's an ENT department which is separate. There is an onco-head and neck surgery. Then we will have breast surgery, GI onco, urology onco, the soft tissue onco, bone and joint onco. So there are all these surgeons and cardiologists work together. In the medical oncology, there will be subspecialties, whether there are soft tissue cancers or whether there are hematological cancers. So all this stuff is in separate buckets, and there are super specialists in each, but they all work together. That's the system that we wanted, and we've been able to transport the system to the rest of our institutions also. Not only are we doing clinical practice, but we are doing a lot of research also as we go along. So that, and if you would have seen that we were able to deliver much superior care to our COVID patients, which became widely known because of the fact that all the specialists, because COVID, as everybody realized, is not a single organ disease. It had affected kidneys, liver, the heart. So all the specialists were there working together to take care of the patient, and that's why our outcomes were much, much better than would be otherwise. So that's, and the research that is happening is basically development of new technologies, of creating the new paradigm for personalized medicine, which is basically the predictive medicine, which we are all working together to actually be able to deliver the personal route a patient's life is going to take. So it's like a personal Janampatri. And that's what has happened because of our, and these are just examples of the technology and all the equipment which anybody can get, but we have it all. Like in cancer, we have 2 linacs, 1 tomotherapy, and 1 cyberknife. So the patient gets what is needed for them, not to say, I have a linac, I'll treat every cancer with a linac. I have a SGRT or, so all the ones who can be treated by cyberknife, which is much more focused and appropriate for some cancers, especially like spinal and brain and all that. That's all benefit that is possible for in Medanta, and that is because of the size of the institution. This is the just a picture of our chairman who have been working together for the last 12 years. And like I said, if you went down, some of it has already been shown, that we are at the frontier of every specialty, and there is a very senior, well-accomplished team in every specialty. So I will not, take time on giving you the whole cast of characters, but needless to say that if you are looking at, like I gave you the example, that all these people will be working together to actually take care of their specific organ so that they can refine. So if you look at it, prostate cancer, we do over 600 robotic cancers a year. So that's a very large number. Our people get so experienced that their results are good because of the fact that there is so much being done. So similarly, like we do close to 300 Whipple operations. Dr. Adarsh Chaudhary is one of the largest. He's got the largest Whipple experience. So there are these kind of things, like I was telling you, in every aspect there is that senior faculty which works at the cutting edge. And now what we are doing across the board, now because we had completed 10 years in the middle of COVID, and we had planned that after 10 years we will reinvent Medanta. So because we got delayed by 2 years, it's being what we call Medanta 2.0 is now in progress. So every institute has the responsibility of looking where medicine will go in their specialty in the next 10 years. So that's now what Medanta's mandate is to everybody, and that's what we are working on. Some of it has been already shown to you, and like we do close to 2,400 joints a year, which is one of the largest, one of the largest. There are other people also who do, and headed by Dr. Rajgopal. So there is, like neurosciences, everybody has done a very good job, so I just don't want to berate it. But the basic thing is, one, people keep asking, why did you come to? So we, as far as transplants are concerned, of course we have always been doing liver. We do the largest number of liver transplants. We do close to 300 kidney transplants, heart transplants, of course, and now we have started, bone marrow, of course, is going on for a long time, but now we've started lung transplant also. So we have just started three months ago. We have already done 6, and there are patients lined up. As the organs become available, it's being done, and we have had 100% success so far. So these are the modalities that have been added on, and we do, like I said, if you look at the pictures, you'll see the leaders in their own right, and the gastroenterology also headed by Dr. Sood. Huge experiences. Adarsh Chaudhary has got like I said, the maximum number of Whipples done so far in this country, and Dr. Soin, who is the liver transplant chief, he does the largest number of living donor liver transplants every year. So, like I said, every institute is doing huge amount of work. We invented robotic kidney transplant, which was done by Dr. Rajesh Alawat. So people from all around the world are coming to learn. Not only that, as part of our belief that traditional medicine has many gems which got lost, so we do have an Ayurvedic hospital inside Medanta, and we are doing a lot of research on neurological recovery and post-op recovery along with the Ayurveds. So we have found that when we've done a comparative study, that the neurological recovery after a stroke is much better if you incorporate Ayurvedic techniques with it, the stimulation that they get from massages and also physiotherapy, the Ayurvedic type, also helps hugely. Because one of the major things of stroke is the contractures and also the stiffness in the muscles and all that. That is actually much less and recover much faster with Ayurvedic massages. So there is a huge value in that. We have recognized it, and this is just a little final statement to say this is the kind of work that has happened in the last 10 years in Medanta. So without taking too much time and standing between your dinner and my speech, I'll end right here. I think you have heard enough of cardiology and the it's basically showing off, but we have done enough of it for tonight. So thank you for coming, and please join us for dinner and drinks as we go out, and it's already quite late. Thank you very much.
We have some presentation to feed off.
Jaldi karo na. Nahi to khatam karo na, because people are hungry.
Sir, 5 minutes mein khatam karenge. So we come to the end of the sessions. So what we have is a felicitation center, felicitation ceremony. So I have been asked to hurry up the whole thing, so I'll do it very fast. The first person I like to invite is Dr. Anuradha Khanna, my esteemed teacher, and he has come all the way to attend and meet Dr. Trehan. Please come, and I'll request Dr. Trehan sir to kindly present her a memento and a shawl. Followed by him is Dr. Nandlal Agarwal, Dr. Nandlal Agarwal sir. Dr. Nandlal Agarwal sir, please come here. You are one of the senior most people in Varanasi whose blessings we have been getting since ages. After him, I will be requesting Dr. Madhulika Singh. Dr. Madhulika Singh, please come here.
Is it just science or also an art dedicated to life? When
I'll request Dr. Ajit Sehgal sir to kindly come on the stage. Dr. Ajit Sehgal sir, he happens to be a senior most orthopedic surgeon of our town. Dr. Kusum Chandra ma'am, Dr. Kusum Chandra ma'am, she is one person who started gynec and obstetrics many decades before. We are fortunate to have her here with Dr. Trehan today.
Medanta. As you enter Medanta, the first thing you see is an expression.
Dr. Madhulika Singh, followed by Dr. I'll request our two more colleagues are here, Dr. Rajneesh Kapoor and Dr. Dilip Dubey. Please go on the stage and please go on helping us in giving the mementos and shawls. And those who have received, please Dr. Ajit Sehgal, sir. Yeah, that is what was lacking. So, Dr. Kusum Chandra ma'am, Dr. Naresh Trehan will be presenting a memento and shawl to her. Dr. Rajiv Ranjan, Dr. Rajiv Ranjan, Secretary, National Neonatology Forum, Varanasi. Dr. Shikha Sachan, Dr. Shikha Sachan, Secretary, Foxy Varanasi, Vox Varanasi. Please keep coming fast. We are just left with few more names. Dr. Akhilesh Singh, Dr. Akhilesh Singh, please come on the stage. I'll request Dr. Rajneesh Kapoor and Dr. Trehan to go on distributing the mementos and shawls together. Dr. Dilip Dubey, please help us out. Dr. Dilip Dubey, please आप भी थोड़ा सा हाथ बढ़ा देंगे तो और जल्दी काम हो जाएगा. Dr. Rajendra Srivastava, senior most pediatrician from Varanasi. Dr. Rajendra Srivastava, President of National Neurology Forum. Please give him a big hand. Dr. P.R. Sinha, Dr. P.R. Sinha, senior most cardiologist of Varanasi. He is here on the stage. We are so privileged to have Dr. P.R. Sinha sir, and I'll request Dr. Trehan to kindly present a bouquet to Dr. P.R. Sinha. Dr. A.K. Kaushik, who is Secretary of Varanasi Surgical Society. Dr. Sudhir Singh, President of Varanasi Surgical Society, in case he is around. Dr. A.K. Kaushik, who happens to be Secretary of Varanasi Surgical Society. We have called all the respective secretaries and presidents. Dr. Sanjay Patel, Dr. Sanjay Patel, Secretary of Academy of Pediatrics, Varanasi. Dr. Sanjay Patel, please come on the stage. Dr. Amit Johri, I think he is not in the hall, I can't see him. Last but not the least, there is one more award to be given and taken, and that is anybody else. Any guesses who is left? So the last memento will be taken by me. I am the President of Academy of Pediatrics Varanasi. So I will be taking the last award, and after that I'll be thanking all the team of doctors all the way from Medanta, Delhi to come here, Medanta, Lucknow also. And thank you so much, sirs. And hope to see you again in Varanasi very soon. And hopefully with Medanta Kashi in years to come. With this, I'll request all of you to kindly come and join us for drinks and dinner. Thank you so much. Sir, one more award is left. That is for Dr. Mohit Kaushik. In case he is around, Dr. Mohit Kaushik has, sir, one more award to be given. I'll request Mr. Abhijit to kindly bring him on the stage. Dr. Mohit Kaushik has scored 12th rank all over the country in All India Institute of Medical Sciences PG exam. So Dr. Trehan, kindly give award to this young chap, Dr. Mohit Kaushik. So, please 3 cheers for Dr. Mohit, who has made us proud by scoring 12th rank in All India Institute of Medical Sciences entrance exam. And fortunately for Dr. Kaushik and popular family, that now both sons of Dr. Kaushik are in All India Institute of Medical Sciences. So, Dr. Mohit needs lot of blessings for all of you. Thank you so much, sir, for giving him your blessings. Thank you so much.